Can you see the message recording? Speak. Oh, well, hello everybody. I'm sorry about the delay. I think after the disruption, we're finally able to get things going. So thank you all for attending today. I'm Nathan Scharf. I'm a child and adolescent psychiatrist who's the Chief of Psychiatric Services at the Youthdale Treatment Centre in Toronto, Ontario. And I've been working for 31 years, primarily on inpatient services, but also consulting on an outpatient basis. And a large part of what I do is managing disruptive behavior disorders in children. So I hope that in our talk today, we're going to be able to discuss issues that are of relevance to you in your practices. I want to say up front that I don't have any particular conflicts of interests or affiliations to any drug companies. I'm not involved in research. So any recommendations that I'm making in terms of an approach to treatment are really based primarily on my clinical experiences. Okay. So just in getting started, the topics we're going to be covering today in the next 45 or 50 minutes are differential diagnosis. We'll be discussing the symptoms and signs that can be used to distinguish one disruptive behavior disorder from another, an approach to treatment. I'll be speaking about medications and briefly touching on monitoring around treatment interventions and follow-up. Very quickly, over here, I've listed some of the conditions that are most often associated with disruptive behavior disorders in children. If you look at the 9 topics listed, for some of them at the top of your screen, numbers 1 to 6, I have listed where the specific conditions are discussed in the DSM-5 and the respective codes that are used in the DSM-5 for those disorders. We'll not really be speaking about substance intoxication and withdrawals. Obviously, these issues can contribute to disruptive behaviors, but aren't primary disorders. And won't really be talking about conduct disorders over here. The distinguishing feature, of course, with conduct disorders is that disruptive behavior in the context of conduct disorder is purposeful and intentional for secondary gain. And, in the other conditions, we're really talking about disruptive behavior as being the result of emotional and secondary behavioral dysregulation. So they're quite different. In terms of first steps, how I approach the problems, usually before I even spend time with the child, I'm going to be spending time with parents or caregivers to get a background history and a history of relevant psychiatric history that will involve the client as well as family members. You want to get a family history of mental health disorders and a sense of the psychosocial challenges that are facing the family. Is it an intact family? Have there been issues with parental separation or divorce, or issues that are locally affecting the community where the child lives? Those are stressors that take place at the micro level. But obviously, people are also subject in their lives to macro influences that can have a significant impact on the development and behavior of young children. Those could be issues such as political violence, effects of war or civil disturbances. Economic failure, collapse can certainly impact on stress levels in families and therefore secondarily on their functioning. We want to go back and get a history of mother's pregnancy, labor, and delivery as it related to the child, and get a sense of what the circumstances that the parents were living in during the pregnancy, as well as intrauterine exposures, because we know that the effects of alcohol and other substances can have a significant impact on the neurological development of children. Then after birth, we're going to be looking at early development milestones. We want to know whether or not any of the milestones were delayed. And we try to get a sense of the nature of the attachment style, as well as any particular disruptions of attachment that might have taken place in the child's early life. We want to know about family systems issues that have been taking place through the years of the child's development. And we also want to specifically be making inquiries about physical challenges or neurological challenges that might have impacted on the child. Okay. Looking at specific conditions, this is also at the level of history taking. While it would be easy to say that we want to do a comprehensive psychiatric and psychosocial history, there are certainly some issues or topics that, at least for me, are going to be more relevant than others. And if we just sort of run down the list of the 10 items that are noted over here, things like ADHD, mood disorders, anxiety disorders, obsessionality, history of compulsive behaviors, rituals, and motor tics will be relevant, because those kinds of conditions will often be associated and directly related to disruptive behaviors, and could be root causes that would be the most directly amenable to treatment. Sensory sensitivities, number 3 that I'm asking about, will be a marker for the possibility of an autism spectrum disorder. Sleep, diet, exercise, exposure to substances, trauma, hobbies, interests. So this is 3, 4, 5, 8, 9, and 10. Over here, we're looking at things like psychosocial development, interpersonal relationships, future orientation, and all of these things will be clues to, issues like self-esteem, how the child feels about his current situation, anxiety, stress, issues with mood. And then, of course, there's 7, paranoid trends, evidence of thought disorder or misperception, which might be early markers of the development of a psychotic illness. Number 6, which I haven't spoken about yet, obviously safety concerns, is speaking about active threat for safety, not only of the child, but those of other family members and people in the community, perhaps related to the disruptive behaviors, but also threats to the child and the possibility that some of the disruptive behaviors are actually a secondary consequence or the child's reaction to an unsafe environment. This, of course, might be a flag for child protection concerns or involvement of child protective services. Okay, moving forward, on this slide, we're speaking about the idea of the importance of physical examination. And, for the record, I'm not physically examining the child myself, but, I would normally expect that any child that's going to be receiving medications, certainly, or might require psychosocial interventions, will certainly benefit from a physical examination, as well as other investigations before we proceed with treatment. But specifically, even in an office where you're not doing a formal physical examination, observing the child, his relationship to you and those other individuals who may be present, whether it's caregivers or parents, will give you an idea of the child's mental health and emotional state. You're going to be looking, when you're observing the child, for any evidence of dysmorphia or asymmetry that might suggest an underlying prenatal insult or evidence of a genetic abnormality. We're going to look at the child's height and weight, and we want to get measurements of BMI. because issues of being significantly overweight or underweight might impact on dosing of medication, appropriateness of medications, and might also be clues to possible genetic or health-related problems. Underweight children, well, it might be related to neglect or food insecurity, or a small stature could be a marker of intrauterine alcohol exposure. Just in observing the child, we're going to be looking for things like what kind of eye contact they make. Do they engage and seem to respond to social cues? Are there any tics or abnormal body movements? There have been cases where I've seen children who seem to be having withdrawal dyskinesias based on recent discontinuation of antipsychotic medicines. Then moving on, number 4, evidence of injury, trauma, or self-harm behavior, whether this is bruising, cuts, fingernails that are worn down because of excessive biting, which might represent either stereotypies or anxiety. And the last one I've listed over here, evidence of intoxication, drug effects, or withdrawal. Review of pertinent data. So apart from a physical examination, I feel it's important, again, particularly if you're going to be considering medication interventions, to be getting baseline laboratory investigations before one considers prescribing medication. Not only is it going to be necessary to obtain liver and kidney functions because they may be relevant to how medicines will be metabolized, we want to be doing screens to make sure that there isn't an issue with anemia or low iron. Low iron will sometimes be associated with periodic limb movements, which can be a disruptor of sleep, which is something we'll speak a little bit about later. And of course, can be a cause for low energy, fatigue, or problems with sedation, poor focus and concentration, iron levels, or anemia. And I also will tend to be doing screens for thyroid function. I'm also generally inclined to do electrocardiograms. In particular, I think that is relevant if one is going to be considering prescribing antidepressant medicines, because we know that the use of antidepressant medicines will sometimes, not commonly, but can be associated with conduction abnormalities in the heart. So it's important to be making inquiries, particularly if one is going to be using antidepressants, of any history that might suggest problems with conduction, and to be proactive in ensuring that there aren't any subtle or hidden cardiac abnormalities. We want to review history of academic functioning. It's often useful to get a sense of how the child has been seen or observed behaviorally as well as cognitively by teachers over the years. And if there's been any old psychological, speech and language pathology or occupational therapy assessments done, those can be particularly relevant for diagnostic issues as well as treatment planning for kids with disruptive behaviors. So those are often quite helpful. You want to get a history of previous hospitalizations, psychiatric interventions, and other treatments, whether with psychotherapy or involvements of other specialists. Sleep studies are something that can be very valuable. And if the child has a history of sleep difficulties, getting one's hands on a copy of old sleep medicine reports or consultations can be very useful. And lastly, number 7, I've noted hearing and vision testing, particularly whether there's school problems or behavioral difficulties at school. You want to make sure that the reason for problems with focus, concentration, or disruptive behavior is not related to either a special sensory problem or challenge, as well as underlying developmental issues or learning disorders. This is just basically kind of a recap of some of the issues that I've just spoken about. On the previous slide, yes, while we're interested in getting older reports if they exist, there are times when getting specific consultations to answer particular questions that come up in the course of reviewing history that can be really useful diagnostically. So speech and language pathology, obviously, if there's any kind of issues with communication, whether that could be stuttering or cluttering or problems with lisps or communication, those can certainly impact on the child's ability to express themselves, as well as self-esteem, and make a child prone or vulnerable to bullying or teasing by peers. Specifically, there could be interest in looking at social pragmatic communication, which is in the domain of speech and language pathology, because we know that social pragmatic communication disorders are one of the areas of difficulty that will often be experienced by kids who are either high functioning with autism or are suspected to have autism, but ultimately are kind of below threshold for diagnosis. Often the issues that these kids have involve not full above the line high functioning autism, but issues either with social pragmatic communication, the route to which for diagnosis might be a speech and language pathology assessment, or it could be related to nonverbal learning disabilities. And, this is where psychological testing will be often necessary to determine either the presence, nature of, and severity of nonverbal learning disabilities. So other kinds of testing, specifically, I'm a big believer of using the ADOS, the Autism Diagnostic Observation Scale, sometimes in conjunction with ADI, the Autism Diagnostic Inventory, for clarity of diagnosis around autism. I say commonly that I don't necessarily trust of either my own diagnoses or even the diagnoses of other psychiatrists when it comes to consideration of high functioning autism, because there has been such a change in the frequency with which the diagnosis has been made in the last 10 to 20 years that, I think the tendency to make the diagnosis on the part of experienced or inexperienced clinicians is such that it is hard to really be assured of the validity and inter-rater reliability of even professionals if they're not using standardized instruments with which to make a diagnosis. So, if I'm suspecting a diagnosis of autism, usually I will be trying to refer where I can to be getting specialized, validated instruments in order to confirm and support a diagnosis. Where kids are subthreshold, again, there may be issues with social pragmatic communication or nonverbal learning disabilities. Okay. So moving on from general considerations of diagnosis to the specifics of episodes of disruption, really what we're talking about is temper outbursts or temper tantrums. So what are the kinds of pieces of information that you're going to want to focus on in terms of understanding? Where you want to be looking at the chronicity of temper outbursts or disruptive episodes? Is this kind of a sudden change of behavior that's been in place for a number of weeks or months? Or basically, has the issue of disruptive behavior been lifelong? How often do outbursts occur? How long do they last for? How are they resolved, or how do they come to an end? What do parents or caregivers do by way of following up with the child, trying to process or discuss what happened, and what kind of consequences is the child experiencing, or are caregivers trying to utilize after outbursts or episodes of disruption take place? We want to be looking at specifically the kinds of behaviors that are taking place during the outburst. And in following up, does the child seem to show any regret or remorse for the behavior? Do they have any insight, or do they just blame and project responsibility outward, as if they're victims of other people entirely without a part to play in terms of the cause of the outburst? Does the child show any evidence of theory of mind? In other words, do they have any insight or awareness of the emotional state or reaction induced in people around them as a result of their behavior? Or do they really kind of see or believe that everybody kind of sees the world and the root causes of the problems as being the same as their own idea of what was behind the outburst? Looking specifically at triggers or any patterns or cyclicity to causes or nature of outburst. Looking at whether or not there's any relationship between the outbursts and physical activity, sleep, health, and looking at the response of the outbursts to interventions. Have there been medicines tried? How effective or helpful have medicines been in containing or controlling outbursts? And what has the child's compliance with medicine been like? So that's a lot of information. And we'll speak a little bit more as we move forward about how that information can be organized. But before we do that, I wanted to speak a little bit about the idea of temperament. And over here, when I'm speaking about temperament, I'm not speaking formally or strictly in the sense of Alexander Thomas or Stella Chess or Jerome Kagan, who've done research on inborn ways of relating to self or others that seem to be innate and present from the child's birth. That might be a strict way of thinking about temperament, but really, I think we can be a little bit more casual about it and really try to understand the child in terms of, and this could be through observation or description of parents, to get a sense of what the child's nature has been growing up. And here's some examples of the kinds of things we might look at. Has the child historically been curious and open to new experiences, or anxious and resistant and adverse to change? Has the child historically been restless and impulsive and flighty, or have they been slow and calm and complacent, or even kind of taciturn? Are they a creature of habit or a lover of novelty? Are they introverted or extroverted? And what we're trying to get at is a sense of the child's nature and whether or not their nature is something that has been relatively stable or shifted quite significantly over time. And we can look at where those shifts have taken place and what causes there may have been to the shifts. Puberty, changes in growth or development, sometimes a move, changes to a new school or in peer groups. Sometimes changes in temperament might be related to the onset of a substance misuse problem or substance abuse, and seeing whether or not changes have been slow in development or there's been consistently over lifespan will be clues to this. So if history suggests that emotional rigidity, inflexibility, poor frustration tolerance, and interpersonal challenges are lifelong, that will pull me in my thinking towards the idea that there may be an underlying inborn or neurodevelopmental component to the disruptive behaviors. It makes me think about looking for problems like an attention deficit hyperactivity disorder, an intermittent explosive disorder, disruptive mood dysregulation disorder, autism spectrum, severe anxiety or panic, sensory issues, cognitive or learning issues, or intrauterine exposures. Here we're talking about, nature or inborn kind of issues. But one of the things I really have to emphasize is the idea of developmental trauma, because, of course, traumatic experiences can take place at any point in the lifespan and can have a long-lasting and very deep-seated impact on social and interpersonal functioning and relationships, as well as behavior. And of course, if the issues are primarily the result of life experience, we don't want to kind of mix those kinds of challenges up with problems that seem to be more inborn or neurodevelopmental, because the diagnosis of developmental trauma will really pull treatment in a different direction. So those are sort of the lifelong, chronic, kind of temperamentally based challenges. But what if we're looking at issues where parents or caregivers or the client themselves are really kind of describing a fairly abrupt shift in how they have been able to function, in more recent weeks or months? That might pull us in the direction of screening for or making diagnoses that involve mood disorders, again, issues that are related to trauma, situational stressors, such as bullying, emotional, physical, and sexual abuse, developing personality pathology, problems with conduct, and again, substances or alcohol that could be behind the disruptive behavior. Speaking at any length about developmental trauma is really beyond the scope of my talk today. Suffice it to say that the issue of developmental trauma and the importance of trauma is very actively becoming a huge topic and focus of social discourse, both in mental health and psychiatric circles, as well as in mainstream media, whether this is the result here in Canada of new and increased recognition and acknowledgement of suffering and injustice imposed on Indigenous people here in this country, or Me Too and Black Lives Matter movements in the United States or internationally, or an increasing awareness in recent weeks in the United States of the impact of gun violence on the mental health and social stability in the United States. These are very politically charged issues, but undoubtedly, are firing a new appreciation of the importance of an impact of trauma on people's mental health and well-being. I've just listed over here a number of references or books that have become published or important recently or in the last number of years that do address some of the issues related to trauma in very meaningful ways. Bessel van der Kolk, of course, is a very important author and contributor to the idea of developmental trauma over the years, and has been actually an important contributor to the child and adolescent psychiatry literature, I believe, that is so important, I guess, in my clinical upbringing. So I'd certainly recommend the book that he wrote, The Body Keeps the Score, which I think is on the bestseller list and has been for an extended period. Okay, I'm going to switch gears a little bit and speak to what I call behavioral logs. So a few minutes ago, I was speaking about the kind of information that you want to get when looking at episodes of disruptive behavior. So what I'll often do is I'll advise parents to keep a little journal or log to monitor episodes of disruptive behavior, because it can be a very useful tool in looking for patterns of function or dysfunction, as well as to monitor response to treatment. So just in terms of general guidelines, and kind of I'll show you a sample of what might be a kind of a typical log. You want parents or caregivers to be able to do something that is not going to take a lot of their time. Typically, I would suggest having them post a piece of paper on the bathroom mirror. So before they go to bed at night, they can spend certainly no more than 4 or 5 minutes completing a little log of what happened in terms of episodes of disruptive behavior during that day. Okay, so the account should look at the number of outbursts, the duration, and relative severity of the outbursts. Then I would kind of suggest a 4 to 5 kind of alarm intensity scale for how difficult the outburst was. I ask parents to note what triggers seemed to precipitate immediately before the outburst, the start of it. Look at situation and context, and to make note of what they actually did and how the child responded to their intervention. Okay, and you can use the logs to develop a kind of a semi-quantitative scale that can be tracked over time or graphed to see how the child is responding to treatments or interventions. So over here, I might have a typical log. I mean, this is sort of formal instruction, but normally this would be kind of handwritten. But basically, this might be parents' marker of episodes over the course of 1 week. And we'll have over here basically, say, if we look at the second entry, the duration was 75 minutes. And we said that the intensity was 3. So this was a pretty bad outburst, but not as bad as some, but maybe worse than most. So because it was 75 minutes, we decided to kind of plot the duration as being 1.25 hours. So because the peak intensity was 3 and it was 1.25 hours, we'll give that 1.25 times 3. So we'll give it a raw score of 3.75. This kind of keeps it simple, but it does give you a number. And then if you kind of add numbers up during a day or during a week, it gives you an ability to kind of graph changes over time. Context. So what was the situation where the outburst appeared? Over here, if you kind of track, you'll see that a couple of the episodes seem to be related to issues with breakfast. More often, the episodes were at home, but it's noteworthy over here. This is a child who will sometimes lose it in the community as well. And it's always interesting to look at whether or not episodes of disruptive behavior are really limited to the home, or whether they occur in situations where the child might experience public scrutiny or potentially shame or humiliation for being unable to control themselves in a public space. Because where you see, situations only taking place at home, it does make you ask more questions about the nature of the home environment, either in terms of how the child is getting needs met from the parents as a result of the behavior, or issues of social awareness or functioning that might limit disruptive behaviors in the community, or potentially situations at home where, child's treatment or relationship with caregivers or siblings is somehow triggering outbursts, where to them, home feels less safe. Okay. And then, issues of intervention, outcome, consequences. These can be used in the context of behavioral analysis to be looking at behavioral interventions and strategies apart from medicines to try to help the child better be able to manage the behaviors moving forward. So again, in terms of the analysis, day of time, you want to look at patterns. If outbursts are taking place, particularly in the morning. You might wonder whether or not this is a child who's hyperactive, and stimulants are really helpful in terms of controlling behavior, but the outbursts are taking place before the stimulants have had a chance to work. Or whether or not a poor night's sleep perhaps is contributing to disruptive behavior. Duration intensity measures I spoke to previously. Location and context, looking for whether or not problems could be related to peer relations, relationships with siblings or parents, power dynamics in the community, or power dynamics at home. Looking at power dynamics in the community, you have to talk about peer relationships and bullying as often being very traumatic to young people and a reason for disruptive behavior. And very often in this context, many kids will learn early that if they become disruptive in response to threats at school, either academic threats, expectations to do work that's really hard for them to do, or fear or experience of mistreatment by peers or other individuals at school, then if they're disruptive, then they'll get sent home. And what happens is that the disruptive behavior is basically a compromise solution that the child has come up with as a way of managing stressors in the environment. When children develop this kind of a dynamic with caregivers or peers, it can often be very, very challenging to get out of those systems. And, it's not a situation where medicines are going to be a natural solution. Okay. Looking at triggers. So I'd mentioned a couple of these issues before. Hyper-reactivity, rigidity, inflexibility, sensory sensitivities, difficulties with peers. These can be clues, again, to underlying diagnostic issues. If a child is having issues with peer relationships, it may be because, they don't understand what they really need to do to fit in with other kids. It could be related to problems with theories of mind, social pragmatic communication, empathy versus sympathy. Well, empathy is kind of understanding the needs of others and other people's situation. Sympathy implies understanding, but also caring in a particular way. So, we might say that a psychopathic child might be empathic. They can read the social cues and get a sense of others, but they won't necessarily be sympathetic towards others. They won't really care, but they're able to gather and use the information for their own purposes, which often will be negative or antisocial. Sensory sensitivities can be a big issue in the classroom in particular. A lot of kids will be very, very sensitive to loud noise, and what is presumed to be an issue with ADHD might actually be quite intimately related to issues involving sensory sensitivity. And, the way to get at that is often through, an occupational therapy assessment or consultation. I've already sort of spoken about what's on this slide, which is looking at how parents and caregivers react and respond to outbursts or disruptive behavior in children will be very telling in terms of the development of behavioral strategies or consequences to try to curtail, prevent, or limit those behaviors. Okay. Going to spend a few minutes here talking about specific syndromes before we get into management and treatment approach. So very quickly, disruptive mood dysregulation disorder. Basically, this is a disorder that will be made in children who have not only a persistent history of outbursts, but also in between outbursts are known to be irritable, moody, and to really have challenges in terms of feeling positive about themselves and social and interpersonal relationships. As such, while this is really a disorder of disruptive behavior, if you go to the DSM, you'll find that it really is classified with disorders of mood, and might kind of be in some ways the idea of a child who's persistently depressed, but the depression maybe it's expressing itself more in terms of irritability and negativity, interpersonal negativity, than through sadness per se. So again, the hallmark of disruptive mood dysregulation is not only that you're having outbursts, but that between outbursts, you're still dealing most of the time with a child that is something of a young curmudgeon. Primary studies have found a variable rate of prevalence of between 0.8 and 3.3%. Other studies, 3.2% of children in the community have chronic problems with irritability and temper, the essential features of DMDD. And interesting to kind of note that parents report approximately 30% of children hospitalized for psychiatric problems will meet criteria for DMDD, but it's kind of half that number criteria based on the observations of hospital staff, which might make one wonder not whether parents are exaggerating or emphasizing symptoms, but whether or not there's an environmental component to the problems with mood or irritability. And when the child is in the hospital, the environment is changing in a way that has a significant impact on the behavior. Okay. Distinguishing that from intermittent explosive disorder, well, intermittent explosive disorder is really a child who is not regulated when they're upset or frustrated. So we have, why don't we say, relatively minor outbursts that are taking place a lot, that's A1, or 3 outbursts or more within a year that involve injury or destruction. So more of the lesser and or less of the more severe outbursts. And then basically the ends, the B, C, D, E, and F criteria are, that there isn't really a better explanation for the problem, and that you don't have the outbursts basically being premeditated. So if you look at the C criteria, basically it's a distinction between a conduct disorder, or what might ultimately be kind of a psychopathic child who is using the behavior to achieve secondary gain. The fact that they would be doing so would be an exclusionary criteria for an intermittent explosive disorder. So for intermittent explosive disorder, a little bit more common than disruptive mood dysregulation, lifetime prevalence of 4 to 6%, 1-year point prevalence between 2 and 2.7%. And in clinical population, one study found incidence of 6.3%. Not surprisingly, boys or men are much more likely to show externalizing disruptive behaviors than women are. Okay. ADHD, I'm just going to sort of speed through this. There's lots of other places where people who are interested can learn about ADHD. Basically, there are symptoms of inattention, and there are symptoms of hyperactivity, and diagnosis will be made on having enough of the criteria for sufficient duration. Prevalence statistics: in 2007, almost 5% of Canadian school-age children were diagnosed. The DSM-5 gives the same prevalence of about 5% for children, about half that for adults. And we all know that there have been very significant increases in the frequency with which ADHD diagnoses have been made over the course of the last 10, 20, 30 years. So, of course, a lot of, perhaps most of the kids who I am referred for issues with disruptive behaviors will have had previous diagnoses, rightly or wrongly, of attention deficit hyperactivity disorders. And one of the things that I really want to spend time discussing with parents and with the children as well is whether or not the child is a child who appears to them to be truly hyperactive and restless, or a child who's really more hyper-reactive. And the kinds of key questions or key issues that I would use to make the distinction between a child who's hyperactive and a child who's hyper-reactive, and of course children can be both hyperactive and reactive, are the issues of poor frustration tolerance, being unable to hear the word no, having a lot of difficulty tolerating unanticipated changes in their structure or routines, reflecting, inflexibility and rigidity. So I won't say anything more about it at this time, but we'll move on, because making the distinction between hyperactivity and hyperreactivity is really, really key. One of the conditions, though, that I think really warrants special mention is essentially what I call fetal alcohol syndrome, or an alcohol-related neurodevelopmental disorder, but in the DSM-5 goes by the name of neurobehavioral disorder associated with prenatal alcohol exposure. So this is in the other neurodevelopmental disorder category, and thought to affect somewhere between 0.2 and 2 out of every 1,000 live births. I think those numbers are low. A diagnosis will be made on the history of intrauterine exposures combined with multiple physical features associated with the condition. And this is really something that's quite contentious, because, I think that it's really presumed by researchers and scientists that most of the children who've had neurocognitive or neurodevelopmental effects as a result of intrauterine exposure will not show physical stigmata associated with the exposure. In any case, if you're looking for physical stigmata, the kinds of things that will be commonly seen will be small stature or growth deficiency, a small head circumference, and facial features involving a thin upper lip, a smooth philtrum, the two kind of vertical lines that normally exist between the nose and the upper lip, and a decreased palpebral fissure, meaning the distance between the eyes will be decreased. So these are sort of the classic typical physical findings associated with intrauterine alcohol exposure. But again, want to emphasize that most children that are believed to have a neurodevelopmental effect will not have the physical findings. So, the question is really, where does this fit into treatment? And because there is no medical treatment for the diagnosis per se, and this will be true for most disruptive behaviors, you're really trying to treat root causes or symptoms and signs. Okay? So having an awareness stored away of fetal alcohol syndrome, I want to speak a little bit about sleep, because sleep is a really important issue in the treatment of these kids, and also in general for the treatment of kids with ADHD. So in clinical practice, sleep problems are reported in 1/4 to 1/2 of individuals with ADHD. and are increased in children with behavioral difficulties. So this is like a really important thing, I think, that often isn't really appreciated. And for me, it is very standard practice for me that if I'm doing a new assessment of a child that's presumed to have ADHD, I'm always going to spend time inquiring about sleep. And if I believe that there is a significant sleep disturbance, I always make it my practice to try to support behavioral change or use medicines or treatments to improve quality of sleep before I'm going to be treating ADHD. Why do I do this? Well, sleep problems can create or mimic symptoms and signs of ADHD, so it becomes a diagnostic confound. And severe ADHD with a sleep problem might become a mild or moderate ADHD if you deal with serious sleep problems. The use of stimulants, of course, will also mask and exacerbate sleep problems because we know that stimulants, particularly if the dosages are too high, can interfere with sleep and make the sleep problem worse. While at the same time, if you give stimulants in the morning, if you take a child who's tired, it will kind of cover over the drowsiness. So if you treat the sleep problems first, you might actually decrease the need for high doses of stimulant medicines. And lastly, if you're dealing with a child who's irritable or shows evidence of excessive physiological arousal, we know that stimulants can increase heart rate, increase blood pressure, and physiologically can exacerbate the physical manifestations and expressions of anxiety. So if there's a situation where anxiety and ADHD are being confused, using stimulants might actually make the problem with anxiety worse and exacerbate the symptoms rather than treat them. Okay, so looking at sleep profile, issues with sleep. Initial insomnia, which could be related to lifestyle, child not having routines, significant issues with different bedtimes being allowed on weeknights compared to weekdays. Electronics and use of phones in bed or at night is a huge problem. Can result in phase delay disorders where the kids aren't getting to sleep until very late, so then naturally they're wanting to sleep in, and then they're getting tired and napping during the day, which makes them not tired at night, which makes them more inclined to want to use electronics in the evening. There could be issues with sleep maintenance, REM or non-REM parasomnias, nightmares, night terrors, fragmented sleep, frequent arousal. So, changes with depression are associated with a significant increase in dream sleep. So if a child is depressed, they may well show on a sleep study increased total dream time, increased REM time, increased proportion of REM to total sleep, increased REM density, meaning more eye movement when they're actually in REM sleep. And of course, you can get insomnia or you can get hypersomnia as well with depression. But getting a sleep study can be useful then in making a diagnosis of a depression in a child, not in terms of DSM criteria, but if you have a child who's showing these kinds of REM changes on a sleep study, one might be inclined to think that antidepressant medicines might be helpful in moderating some of the symptoms of irritability or disruptive behavior. Full montage EEGs may be necessary if there's a concern over a possible seizure disorder. And usual sleep studies, at least with most of the sleep clinics that I'm aware of, will do 12-lead EEGs, and you might need a 24-lead or a full montage in order to rule out seizure activity. Primary disorders of sleep, restless leg syndrome. Remember, this can be associated with low iron levels. So getting iron levels or treating with iron supplementation might improve sleep in that context. Anxiety disorders might result in fragmented sleep or an increased number of arousals noted. Problems with sleep may be related to physical pain. Iatrogenic sleep disorders, side effects of medications such as too high doses of stimulants can interfere with sleep. Lifestyle-related sleep problems, kids who just don't want to sleep, they want to be socializing with friends. Problems with sleep related to substances or issues with phase delay resulting from scheduling issues, or a home environment that doesn't really allow for privacy and peace and quiet and dark spaces that are going to be conducive to sleep. If one is looking for a quick screener to kind of make sure that sleep isn't an issue that needs to be treated, well, there's the Bears Mnemonic, which is sort of self-explanatory as a list of questions. If one gets one or more hits on this questionnaire, it probably means that there's enough of a concern around sleep that further inquire around the details and possibly either direct treatment or referral for a sleep medicine consultation will be necessary. Okay, so treating disruptive behavior, same thing as treating attention deficit hyperactivity disorder. For me, I will treat sleep first. So just very quickly to touch on that, over-the-counter preparations. Well, these might include melatonin or tryptophan. Melatonin, easy to use, available without a prescription, over the counter, more useful, at least in my experience, for initial insomnia rather than parasomnias. It'll help kids fall asleep, but if there's issues with sleep maintenance, it won't necessarily do a good job with maintaining sleep. Tryptophan might be more useful in that regard. The issue is that often very high doses of tryptophan are needed. And if one is going to be gradually increasing tryptophan, it can take a long time and it can be unwieldy, the amount of tryptophan that's needed in order to promote sleep. Nevertheless, if people are looking for natural options and want to avoid prescription hypnotics, tryptophan might be a reasonable alternative to consider. Okay. Sleep apnea. Well, if there's a child who is found on a sleep study that has sleep apnea, it may require an ear, nose, and throat consultation to make sure that an upper airway obstruction isn't the cause. Sleep apnea is, of course, often associated with obesity, so weight loss and dieting might be necessary. And if it's severe enough, continuous positive airway pressure, CPAP might be necessary as a treatment, but this is not an easy solution. Nevertheless, severe sleep apnea can be life-threatening, so it's something that one certainly can't ignore. And one wouldn't want to immediately treat with hypnotics if the problem was sleep apnea, because you don't want to interfere with the brain's natural tendency to awaken itself, if respiration is being interfered with by the sleep state. Periodic limb movements, I've mentioned before. Gabapentin or clonazepam will sometimes be employed as treatments if it is an issue with iron and if periodic limb movements are significantly disturbing sleep. If a depression is diagnosed related to a sleep study or not, well, I will certainly prescribe antidepressants to children, but specifically, there will be some clients where there's a history of mood disorder, post-traumatic stress disorder, or complex trauma, where a lot of sleep disturbance is being experienced. And these are individuals who could be very, very dysregulated with huge problems with anger management or temper. Mirtazapine at night will often do double duty, as a useful medication to help with depression and PTSD symptoms, as well as difficulties with sleep and nightmares. Trazodone can work well as well because of having come across some situations of trazodone causing priapism in males. I do not personally prescribe trazodone for males. I'll use mirtazapine, but because mirtazapine I find is more likely to cause increased appetite and weight gain than trazodone, some individuals may prefer trazodone, although I do tend to limit that to biological females. Okay. If I'm looking for a hypnotic where I'm not trying to get double duty for anxiolytic or antidepressant effects, and there aren't other situations that warrant more specific treatment, I find zopiclone to be a generally quite effective and well-tolerated medication. Of course, one should avoid, where possible, using any hypnotic agent on a long-term basis. Okay, so after dealing with sleep, for a child who has disruptive behaviors, if they have a concurrent attention deficit hyperactivity disorder, and I've taken care of the sleep, what I'm going to typically do as a second step, or it would be the first step, very often, if there was no sleep problem, is I will treat the ADHD. So, stimulant medicines, and, there could be pros and cons argued for any of them, but frankly, I don't think it really makes a huge difference, what stimulant medicine to use as a first choice. All of the stimulants might have same or similar issues in terms of effects and side effects. Of course, depending on the individual, one might work better or worse. The main thing is, though, is that, as I've mentioned previously, if you have a child who's irritable, and many of these kids are irritable, or they're anxious, and the irritability is kind of an anxiety equivalent, particularly if we think about anxiety as being manifest in physiological or autonomic nervous system arousal, stimulants can exacerbate the problems. So, while stimulants will certainly be effective treatments for ADHD, the concern is in these irritable or dysregulated youth, helping the ADHD, but worsening irritability. So I'll often start with a stimulant, but you have to look at tolerance. And, if you start to see any exacerbation of anxiety or irritability, you can often help the problem in these situations by decreasing the stimulant dosage and cross-titrating with the use of an alpha-adrenergic agent such as clonidine or guanfacine, or sometimes I've had some success with atomoxetine. So whereas I think most clinicians will find that clonidine and guanfacine are harder to use and less effective, and I'd say the same thing for atomoxetine, less effective for truly hyperactive kids, they can be effective for those kids where the issues are more inattentive and or there seems to be issues of anxiety or irritability compounding the problem with ADHD. Similarly, if I have a child who's hyperactive and doing really well on stimulants, but they're experiencing a lot of problems with appetite suppression or weight loss as a result of stimulants, sometimes I've been able to get improved results, better tolerance of the use of stimulants if I lower the stimulant dose, but I add in clonidine, guanfacine, or atomoxetine as adjunctive agents. As I'd mentioned, the use of second-line agents may well be related to their tendency to treat autonomic nervous system arousal or stress responses that are basically mimicking the signs of ADHD. For some of these kids, the issue is that parents are complaining that stimulants don't work, when the fact is that the stimulants themselves are working, but the metabolic response or effectiveness of the medicine is much shorter than what people would hope. So you'll have children where, the duration of a Concerta or a Bifenton, which might be expected to be 10, 12, 13, 14 hours, is actually only 4, 5, 6 hours. And because these medicines are advertised as once-a-day treatments, people will think very often that all they need to do, if parents are complaining that the medicines aren't helpful, is to increase the dosage. But the problem is that, of course, if the concern is really rapid metabolism, then increasing the dosage of a once-a-day preparation is only going to increase blood levels more than duration of effect. So unfortunately, in these situations, it's often necessary to use either a long-acting preparation, perhaps morning or at midday, or to supplement a long-acting medication in the morning with a short-acting medication at midday or perhaps early afternoon. Okay, if there's evidence of anxiety, obsessions, compulsions, depression, post-traumatic stress disorder, or complex trauma, separate from ADHD or in addition to ADHD, then it'll often be helpful to be adding in an antidepressant medicine in that case. Now, I mentioned previously, if there were concurrent sleep problems, I might be inclined to use something like mirtazapine or trazodone. But those medicines are ones that I'll reserve in special cases where I'm really concerned about sleep issues. In general, I think much more typical and appropriate treatment would be to start with a standard approved first-line agent for the treatment of anxiety or OCD or depression in children. And these are typically selective serotonin reuptake inhibitors. So this, again, might be in combination with a stimulant or perhaps a medicine that's being used specifically for sleep. Many clinicians will consider adding a second or third generation antipsychotic at this point. If you've got a child with ADHD and they're dysregulated and the stimulant isn't completely helpful, people will often add risperidone, olanzapine, quetiapine. I would really want to discourage that practice. We'll speak a little bit more about it later. I feel that these medicines absolutely can be sedating, but are not beyond their sedating effect and their potential to perhaps slow down aggressive actions or temper outbursts simply through broad-based sedation are not treatments that I feel effectively target root causes for outbursts. Apart from the antidepressants, then, if I'm moving on and a medication needs to be added to the regimen, I will occasionally try buspirone, either on an as-needed or on a standing basis. Certainly because of risks of addiction, misuse, dependency, or disinhibition, I feel buspirone is a preferable choice before using benzodiazepines, and because of metabolic side effects or potentially toxicity or even withdrawal dyskinesias, I feel that buspirone is more appropriate to try than antipsychotic medicines. So, approach to treatment before even going to medicines for disruptive behaviors. Psychoeducation to parents and caregivers, involving school and day treatment programs in developing a management plan. Parental support is very valuable. This is support to the parents, not support of the parents, although you need that too. In-home support or respite where it's possible or appropriate. When parents are trying to impose consequences for behavior, if their child is able to accept consequences and process around it, you don't want to be delaying consequences. It's not, well, now you're not going to get a birthday party in a month, or Santa's not going to be so good for you at Christmas, or wait until your dad gets home. Justice delayed is justice denied. And often for these kids who are irritable and impulsive, not only is it torture for everybody involved to wait for the other shoe to drop, but very often the child, if the consequence is significantly delayed, will not, why don't we say, psychologically or behaviorally make a clear and solid connection between the behavior and the consequence. So the value of the consequence in modifying behavior will be that much more limited. You want to set appropriate expectations for treatment with parents. And this is really, really critical because, and I'll speak about this a little bit later, you know, the effects or the outcomes of treating disruptive behavior is rarely where effective treatment will result in either a very significant improvement or a very rapid change in behavior. Single interventions may have very significant but limited effects. So, you know, you want to remove from parents and caregivers the idea that it's reasonable to expect that a single intervention will make a very substantial change in behavior or will work very quickly. This is a game of inches that you engage in over time. Okay. Looking at role of medicines in treatment, etiology is very relevant to consideration of what medicine to use. Building on what I was just saying previously, while it's clear that medications can decrease aggressive behavior and disruptive behaviors, using medicine is not often very effective in isolation of other supports, strategies, or interventions. You know, if you're thinking about using medicines, you don't want to be giving a single medicine to a child and telling the parents that this is going to make a big difference. And you shouldn't be expecting it yourself. This is not an issue of home runs. So you shouldn't be looking for dramatic results from single interventions. And the medications really, where possible, should focus on the treatment of specific syndromes where there's clear etiologies, rather than targeting disruptive behaviors per se. So if one feels that the problem behind the disruptive behavior is a child's misunderstanding of social cues and meanings, or rigidity or intolerance of training that's related to autism, really you're looking for interventions to treat the underlying autism, not the underlying behaviors. If the problem is irritability as a result of the child being, cranky from inadequate sleep, you know, you're going to want to treat the sleep problem and then kind of measure for improvements in disruptive behavior as resulting from the intervention around sleep. Review current medicines that are being employed and a history of prior medications and responses, sensitivities, and tolerance. So, you know, in my practice, it's more common for me to see a child for the first time who's taking 2 or 3 medicines simultaneously, rather than to see a child who is not on any medicines for disruptive behavior. So before you're going to be adding in new medicines or treatments, you really want to be reviewing specifically what the benefit and response was to the medicines that the child is already having. So the goal is to simplify the treatment regimen, focus on using medicines that have better safety profiles and are easier to monitor and use before you start looking at medicines that have more complicated metabolic profiles or need longer periods of treatment in order to gauge response. And, you know, you want to be using medicines that could be given on an as-needed basis in the perfect world before you're going to be using medicines that need to be given 24/7. So a lot of this is common sense stuff, but I think what I want to emphasize is that one needs to be very systematic in the approach. So before using medicines, as I said previously, you want to get baseline laboratory evaluation. The role and value of pharmacogenetic profiling. So here in Canada nowadays, if a parent has $1,000 to spend, you know, they can spend $1,000 and go get basically a profile of their child's metabolic profile as it would relate to the breakdown and, well, we'll say sensitivity to dosage of a wide range of psychotropic medicines. These genetic profiles are looking at isoenzymes or variants of the enzymes involved in breakdown of the various psychiatric drugs. So, what is the role or value of getting these profiles in determining treatment? Well, for me, they can be useful as a general guide to dosing of medicine, but they are not a guide to which medicines are going to be most effective in the treatment of disruptive behavior or other disorders. Because primarily these profiles are looking at breakdown of the medicine in the body, not uptake and effect of these medicines on neurotransmission in the brain. So, while it can be a guide to whether or not a child will likely need unusually high doses of a particular medicine or might be particularly sensitive to low doses or the side effects of medicines, that information can be helpful. But frankly, as I'm generally going to be starting with very low dosages of medicine and titrating to response, rather than starting with high or even standard dosages of medicine, getting the information in advance as a guide is a little bit of a luxury. And frankly, to the way that I practice, is not usually necessary or worth the cost of the testing unless parents are particularly feeling that they want it and money is no object. You want to be tracking height, weight, BMI, and of course, inquiring about allergies before starting medicines or making changes. You want to be considering periodically plans to taper or discontinue current medicines where there's poor or limited evidence that the current medicines are useful. And ideally, you want to be doing that before you're starting new medicines. But often urgency of behavior or concerns about stopping medicines that parents aren't sure whether they're helpful is difficult to do in the community because of the anxiety. And, if you're not going to be looking to hospitalize a child, you may be disinclined to stop medicines before considering new ones. Really, really important. I never, if I can possibly avoid it, make more than one medication change at a time, because I don't want there to be any confounds around, if behavior improves or deteriorates, is it a result of the addition of a new medicine or the removal or decreasing dose of another medicine? So I always try to stagger things by at least a few days if I can. While I certainly done most of my career as an inpatient psychiatrist, and I'm quite comfortable and familiar with making medication changes in hospital, really, I'm very resistant to doing this in a hospital, if only because hospitals are very abnormal environments. And if a child is doing well in hospital, it's very hard to extrapolate from improvements in behavior in hospital to how the child is going to do back in the community, or the effects of the medicine in the community in comparison to how well it seemed to work during a relatively brief hospitalization. So where possible, you always want to make changes in the real world. And when I'm doing consultation, I find it very unhelpful to do one-off consultations to parents. I really feel that effective consultation for disruptive behavior is an ongoing process that will often take between 3 or 6 months if multiple medication changes are going to be required. So start by treating what is most directly treatable. That's often ADHD, because the medicines that are used for ADHD are clearly effective, and you can judge their response relatively quickly. But you want to make sure if you're treating ADHD first, that there isn't going to be confusion around anxiety problems or irritability. I'll often use buspirone for the treatment of generalized anxiety disorder as a second-line agent, usually after SSRIs. SSRIs are more standard, but if I'm getting an incomplete response and I feel that evidence of anxiety or irritability is notably persistent, I might well add in buspirone. I haven't seen any challenges of using the two medicines concurrently. A little bit more information about buspirone. Buspirone as an anti-anxiety agent works differently from benzodiazepines. It works on sort of 5-hydroxytryptamine transmission rather than gamma aminobutyric acid or GABA as benzodiazepines or alcohol will. And therefore, buspirone is really presumed to have much less potential for abuse or addiction. A little bit more information on buspirone. As I said, strong affinity for serotonin 5-hydroxytryptamine 1A receptors, acting as a partial agonist. It's proposed from increased serotonergic activity in the amygdala and other parts of the brain, anxiety, fear circuit, and no effect on benzodiazepine GABA receptors. Lastly, second generation antipsychotics. So how have we gotten into this tradition of using antipsychotic medicines for disruptive behavior? Certainly in my training and in practice, antipsychotics would most commonly be used to sedate or calm agitated individuals in emergency departments. And I believe that kind of as a crisis intervention. Yes, it's true that antipsychotics can be sedating, but while there has been research looking at the effects of antipsychotics and other treatment interventions on disruptive behavior in children, the evidence for the use of these agents in populations other than those with quite significant developmental disabilities or autism, or perhaps psychotic illnesses, is really very limited or poor. The outcomes that people seem to be extrapolating to general populations with disruptive behavior is based on evidence that was really related most specifically to the populations I mentioned above, individuals with low IQ or autism, where there may be more specific value of antipsychotic medicines. So they really don't work anywhere as well in the other populations like intermittent explosive disorder, disruptive behavior disorders, and I would say in high functioning autism also limited value, but the same tendency to side effects, often metabolic changes, significant weight gain, sedation without much other benefit is what I'll often see. So we'll avoid using them where possible. So just in winding up, in summary, treat symptoms and signs rather than diagnoses per se. Take a good history. Be mindful of trauma, situational stressors, and markers of mood disorder, intrauterine exposures, anxiety, rigidity, inflexibility, ASD, ADHD, and trauma. And certainly don't forget sleep. I encourage parents to do logs so you can monitor the progress of treatment, because parents, tend to respond to crises, and you can sometimes get over time very significant improvements in frequency and intensity of outbursts, but then there's a crisis and a bad day and you get phone calls from parents, the medicines aren't working. When in fact, if you track changes over time, there can be quite significant changes, but the changes are subtle and gradual. And if you just focus on the here and now, you often lose sight of progress made. Support parents and children, parents and caregivers in utilizing resources. Use psychoeducation. Treatment in the community is preferable. Make one change to medicine at a time. Your time frame to monitor change is weeks to months, not days to weeks. Remove equivocal medications, ones that you're not sure if they're helpful, before adding new ones where you can. Employ safer and less intrusive medications prior to those requiring closer monitoring or more side effects. Treat sleep problems first. Note improvements that you might see in irritability and ADHD if the child's sleeping better. Treat ADHD next if it's present. Then I would move on to anxiety and mood symptoms, Complex trauma is challenging. It's not only going to be medicines, there's going to be a need for very involved therapies as well. Avoid using antipsychotics where possible. Most of the evidence for their effectiveness is in the treatment of developmental disorders or autism, and be sure to monitor closely for side effects. Often takes months to do a complete comprehensive assessment and medication review. Work actively with community partners and service providers. Applied behavioral analysis can be helpful, particularly with autism or developmental disabilities. Occupational therapy can be very helpful for dealing with sensory sensitivities. And consultation takes time. And it really does take a village, a community of service providers and caregivers to work effectively with these kids. So that is it. Thank you for your patience and cooperation. Sorry about the technical issues that led to the delay in the meeting. I would be very happy to take some time for questions. I see there was a question submitted, so I will start with that. The question is it wise to let the child do too many after-school groups? My 5-year-old child does after-school German class, football, dance, science class, swimming, ninja group. I sometimes think it's overkill, overstimulation, and he often misbehaves when we have family time. He sleeps well, but eats very fussily and bad, which is down to us being busy, irresponsible parents as well. Well, thanks for the question. It sort of seems like you've answered the question yourself. You know, I think structure is very good, but of course, kids live much more programmed and regulated lives nowadays than they did when we were children. I think that, you know, I would generally suggest for most parents who are interested in involving their kids in extracurriculars that you have to be selective. And, you know, if, for example, one was going to consider involving their child in more than 2 activities that were extracurricular and that were structured and formal, I would say, you know, make it one child that is one activity that is absolutely the child's preference. And, you know, I would barter that off with the other activity, whether it was math tutoring or a language group or Kumon or an activity that you felt was important, either as a cultural or personal or family value or belief that the child was less interested in. But I think it's really important that every child will benefit from and is entitled to and deserves opportunities for downtime. One thing I would emphasize over here is you're mentioning sleeping well, but eating fussy and bad. Well, you know, diet and exercise, of course, are key to mental and physical health. Okay, next question. What approach to medicine escalations would you recommend for severe hoarding disorder in a child? Hoards trash to the point of being unable to be in the cafeteria for a month. Now back, but she steals her friend's trash to bring home when they're not looking. Currently on 100 milligrams of Zoloft. Well, I will say, I have a couple of kids in my practice with severe and refractory OCD, and the OCD is the main issue. It sounds from this question that we're not really talking about disruptive behaviors, as in intermittent explosive disorder, DMDD. We're talking about what seems to be compulsive hoarding in the context of an obsessive compulsive disorder. And the treatment of 100 milligrams of Zoloft might be appropriate in that context. So what do you do? First of all, you know, number one is hoarding is probably amongst the most difficult and challenging of the obsessive compulsive behavior disorders to treat effectively. Response rates to medications for hoarding are pretty low. I'd say in comparison to the effectiveness of medication treatment for other kinds of OCD behaviors. Specifically, I would say it might be appropriate to either increase the dosage of the Zoloft or switch to another medicine, assuming that the child isn't experiencing side effects. Dosing can be tricky around OCD. We know that in general, effective treatment with medicines for OCD requires longer duration of treatments and often higher dosages of medicines than will be necessary for anxiety disorders and mood disorders. But again, hoarding is often particularly refractory. I would presume and expect that separate from raising the medicine or trying an alternative SSRI, or sometimes clinicians will use clomipramine, and sometimes clinicians, if they don't get much or sufficient response, will try to add in antipsychotic medicines, but I think the yields on that are low. Really, I think that the core of the management is going to be a cognitive behavioral therapy. And, it might be very tough sledding for a cognitive behavior therapy. The only other thing that I would add is have people ensured that there are not other attitudes or behaviors that might be suggestive of a pervasive developmental disorder. Because there could be things that would be missed. But if it's a pure hoarding OCD, I would kind of be forced to make the recommendations that I've made. Higher dosages, alternative medicines, but the focus would probably be with talking therapies or behavioral therapies. Okay. So I don't think that we have other questions right now. So I want to thank you for attending to my talk today. I hope that it will be of value to you in your practices moving forward. I want to thank the people at MDforLives, MDforLives.com for sponsoring the time today, and be sure to sign up to the site and recommend your colleagues to these seminars. Thanks very much for taking the time with me today. Bye-bye now.